and dear friends. My topic is Interleukin-18, a therapeutic target for primary glaucoma. As we all know that most of the glaucoma treatment is on IOP lowering, and we know there are failures. So we need to look at other factors that are responsible for RGC cell death and trabecular meshwork closure that can be monitored and modified so that they can help in treatment. Now, why IL-18 here? Well, IL-18 is a pro-inflammatory cytokine which is known to be involved in neuroinflammation and activation of immune cells in the brain, and is known to be elevated in Alzheimer's, multiple sclerosis, etc. And secondly, it also has its role in tissue fibrosis and is known to have its role in pulmonary, cardiac, and liver fibrosis. So we will be looking at trabecular meshwork fibrosis. Now, how do we monitor it in glaucoma? So the aim of our study was to determine the status of IL-18 in aqueous humor of primary glaucoma patients and study its causative role. Also in reference to its severity, progression, and response to IOP lowering treatments, and also to validate the tests in vitro. So what did we do? We collected aqueous humor of cataract patients, 77 controls, and primary glaucoma patients, 137, and did ELISA. We excluded other secondary glaucomas, and also we did in vitro studies. Well, our cohort was glaucoma, which was divided into severe and non-severe based on VFI. These patients were followed up for 1 year and followed as stable and progressors based on VFI drop per year. Then we also looked at patients who were not responding to the glaucoma medications, and also after trabeculectomy after 1 year, whether they required medication or not medication. Now, based on that, we checked this is the cohort, which is more or less similar with the difference in intraocular pressure. So our findings were that interleukin-18 was found to be more in glaucoma patients as compared to normal, and it was significant. Then, when we looked at the severity basis, we found that IL-18 levels were significantly higher in severe disease as compared to non-severe group. When we looked at the progression, that means VFI change, there also we found that IL-18 was found higher in the progressor groups as compared to the stable group, and it was significant. When we looked at the response to therapy, when patients responding poorly to AGM or medication were found to have higher IL-18 levels as compared to the ones which were responding well. And similarly, response to trabeculectomy also was found to be poor in patients who have higher IL-18 values. When we looked at the effect in vitro, so we looked at the cell lines and looked at different dosages of IL-18, if you see these higher doses, and the neurite length is being reduced. So we found that IL-18 was reducing the cell neurite length, but not affecting the viability. So to summarize, the IL-18 and disease association was clearly seen, and it was significantly higher values of IL-18 in patients with primary glaucoma and the severe form of disease, progressors, and non-responders. And also the similar findings we found in the in vitro cell lines, neuronal cell lines. So what do we know already about IL-18 is that the raised intraocular pressure in mouse models and dogs is associated with higher IL-18 levels, and IL-18 inhibitor is known to improve RGC survival in animal models. What this study adds is that IL-18 and glaucoma patients, there is an association of higher IL-18 levels with glaucoma and also the severe form of the disease, non-responders, and progressors. And we also found that in vitro, IL-18 is detrimental to the neurite length. So this study clearly bridges the species gap. We first time find in the human studies that IL-18 is linked. Now, what does it take us to the future? It can be useful in clinics for prognostication and risk stratification. We can do mechanistic and preclinical studies and have a new target, a therapeutic target in glaucoma patients. There are already drugs which are available which block IL-18 and are being used in trials like Crohn's disease, atopic dermatitis, and Still disease, etc. And these same drugs can be useful in future for glaucoma. There are IL-18 blockers which are already used for RGC survivors, and the existing drugs itself can be used for treatment in glaucoma in addition to our conventional glaucoma therapy. So that's an important step towards a new modality of treatment or next generation glaucoma therapy. With this, I would like to thank our clinical team, research team, and my co-investigators who have helped in the study, and also thanks a lot for listening to me.
Question, ma'am. The IL-18 levels, if they are high, they are toxic. And if they're too low also, then also, because they have some neuroprotective role also, it has been shown in the studies.
That's right.
So how do you modulate that, and how often do you take a sample to check whether the levels are in that level, the ideal level?
So when we are looking at IL-18 increased level in this particular group of patients for study purpose, it is in comparison to the normal group, which we have taken aqueous samples of cataract patients, which are being operated for cataract. So that is our control. The levels in the cataract patients and primary glaucoma patients were compared to that. Similarly, when we compare the severity, non-severity, everywhere baseline is that cataract patients where there are no other neurodegenerative or vascular diseases.
So how often do you take a sample to see? Have you given them treatment to them and seen that whether the levels have decreased or not?
No. So this is for the study purpose. This study was conducted in last 4 years. So all the patients who are undergoing trabeculectomy for primary glaucoma, the aqueous samples were taken to look at these levels. Now, when we translate into the clinical stuff, then we can actually predict. So at this point in time, the clinical application would be when we are operating a patient with trabeculectomy and take a aqueous sample, and you see that IL-18 levels are higher, you know this patient can fail. So you can look at other modalities of treatment, or can be more aggressive in treatment, or can give follow-up. The IL-18 blockers, which are available right now, are not yet tested for glaucoma. So that is the future therapeutic potential target. Right now, we can use it only for prognostication and risk stratification.
Thank you.
Be the cost of this?
Well, interestingly, now we have these biomarker kit, which is available in the sense that NN has created a biomarker kit where you can actually put the aqueous sample and get the results in, say, 45 minutes or so. That is going to be available. It's already at the level of distribution. So the cost is not going to be very high for the patients. The kit may cost, say, 20 to 25K at this point in time because that's a new thing that has come up.
Okay. Thank you.
Just one thing more. See, Interleukin-18, specifically, it's significantly more in neovascular glaucoma and pseudo-excitation glaucoma compared to POEG. So would you think this will have more relevance there rather than POEG? POEG is not supposed to be, the studies which have been conducted vis-a-vis the neovascular glaucoma, pseudo-excitation and POEG, there's not supposed to be that significant interleukin raising the levels.
Yeah, sir. Incidentally, we are also doing, looking at the other molecules. So in terms of neovascular glaucoma and where we have other secondary glaucomas, we found that VEGFs and TGF-beta has found to be more relevant as compared to IL-18. IL-18 has been found to be more relevant in primary glaucoma. So this was beyond the scope of this study, so I did not present those molecules.
Have you specified the non-responders in your study?
Non-responders.
You just mentioned that they were non-responders,
Yeah.
but did you
So
specify what are the reasons for
there are two
non-responders?
types of non-responders, sir. When we looked at patients who were given IOP lowering drugs and they did not respond to drugs and had to undergo trabeculectomy over a 1-year follow-up.
I agree, but you should have at
medication.
least specified in your study as to what you classified as non-responders and the severity and the non-severities. Thank you.
Okay.
I'm sorry.
Thank you. Thank you.
Thanks.
Dr. Navdeep, over.